Welcome to the CUGH Faculty Development Webinar Series, Teaching Global Health through an Interprofessional Lens. I'm Dr. Jessica Everett, Executive Director of Child Family Health International and Associate Clinical Professor at UCSF Department of Family and Community Medicine. Child Family Health International is excited to collaborate with CUGH on this webinar series. The goal of the webinar series is really to equip faculty to integrate other disciplines' approaches, including vocabulary, concepts, and case studies, into our teaching so that we can present a truly interprofessional, multidisciplinary understanding of global health to learners and trainees. The previous installments of the webinar series include Global Health and Law, presented by Virginia Rawthorne from University of Maryland, Baltimore, Global Health and Anthropology, presented by Dr. Peter Brown from Emory University, and Global Health and Engineering, presented by Dr. Shannon Marquez from Drexel University. All these webinars can be found open access on CUGH's website under Past Events. If you go to the About menu, scroll down to Events, and then scroll down to Past Events, and you will see all the past events available through CUGH, which is a wonderful resource for all of those teaching, learning, and practicing global health. This webinar series is sponsored by Child Family Health International, which is a nonprofit based in San Francisco that provides global health field experiences for undergraduate, graduate, and postgraduate students. We partner with universities in order to enable global learning in a way that upholds ethical values and ensures integrity in the community-based experience. Our tagline is "Let the world change you," and we really challenge students to learn about global health through the complex lens of local leaders. Learn more at www.cfhi.org. I want to also point out a couple of resources that were just published. The Preparing for International Health Experiences, a practical guide, is aimed at students to help them prepare for global health experiences, with a specific eye to ensuring that students are not practicing beyond their expertise and are not perpetuating neocolonial misunderstandings about global health in international communities. The Global Health Experiential Learning from Theory to Practice is a textbook aimed at faculty, staff, and administrators to ensure integrity, pre-departure training, ethics, and rigor in experiential education, as well as respect for local populations and strengths-based approaches. You can get these on Amazon.com or a multitude of online booksellers. This webinar series was inspired by this article, which was published in 2015 in the Annals of Global Health, which was the first article to really identify, through consensus, a set of competencies for interprofessional global health learners. This article, importantly, defined different levels of proficiency, which was the first time this was done. This is so important because learners to ensure they are at the appropriate level of action and learning when they are developing their global health understanding. This article brought together over 24 competency sets from many large organizations, most of which are based in the global north. This study was then done to try to understand more perspectives from host and partner communities that are located in the global south. This article brings together researchers from 9 countries to look at host community perspectives on what learners should learn and how they should develop. This has inspired this webinar series to really help capacitate us as faculty to teach and do justice to global health through a multitude of frameworks. I want to welcome our speaker today. Robert CUGH is from Dalhousie University and is an associate professor in the Department of International Development Studies. He's published widely, particularly on the role of Cuba in health engagement worldwide, as well as the realities behind health disparities, and he is truly an inspiration for many students as well as colleagues. Thank you, Dr. CUGH, for being with us today. I'm going to turn the presentation over to Dr. CUGH now.
Great. Good afternoon, everybody, and good morning to some, depending where you're joining us from. Sorry, just a technical glitch here. There we go. Great, good afternoon, and thanks for the opportunity to talk to you all today about the place of geography in global health. And I will make a few admissions right off the bat that today I will not have the ability to go through the entirety of geographic methods and approaches to global health. It's just simply too vast. So I will try to give you a heads up as to what the discipline gives to global health and respectively what global health gives back to the discipline. And from there, I want to share a couple pieces of my own research that will take us to Cuba, to West Africa, and to the Arctic. And hopefully that will give you a sense of what geographers do in global health and how we approach it. So to start off, as a geographer, I have a trade union obligation to put up a map. And there's my map. And for those of you who are map enthusiasts or who are fans of the West Wing, you'll know that this is a Peters projection of the world. It's a territorial representation of the Earth so that territories that are large look respectively large. Hence why you see that Sudan is large, England is small. It's always a challenge when you put a three-dimensional object on a two-dimensional space. There will always be distortion. And this is one of the inherent problems that we have in geography, is how do we actually map the world? But geographers also know that maps can tell different stories. So if we switch the gaze of this map from away from the size of the territory to how the world looks by population, we see some distortions. We see India and China swell up quite a bit. Japan swells up. Europe is rather large, and places like Canada shrink considerably, and New Zealand is pretty much gone because you've got 4 million people and 40 million sheep, so it's not going to show up on a map like this very well. That said, in global health, we're able to get maps to tell a collection of stories. So if we look at this map here, the proportion of vaccine preventable deaths, we see that it really doesn't impact the Western Hemisphere as much as it does places like India, Pakistan, and Nigeria, for example, here. If we look at the proportional amount of polio cases, we see it's an overwhelming burden in parts of India, Pakistan, Nigeria, and the Democratic Republic of the Congo. Not so much an issue in the West. Now, the thing about these maps, when we look at the proportional amount of infant mortality, we can clearly see where a great deal of the global health burden lies. The mistake is to think that this is somehow inherently connected to these places. So what I mean by this is if we look at the proportional amount of mortality from preventable causes, we see that the overwhelming burden falls into poor countries such as Haiti. We see the continental burden on Africa and the Indian subcontinent quite large. 18.6 million preventable deaths a year, almost 50,000 a day. And the misunderstanding, the mistake that can be made is if we assume that these mortalities are inherently connected to these places. And today I want to show you why that is the case, because the amount of mortality that's connected to such regions of the world is no more structured than, say, the proportional amount of doctors to each territory. In this case, we see Africa is gone pretty much on this map. So again, the determinants of health within a place are complicated. And what we see from these maps more than anything is that there's an incredible global inequity in terms of who gets access to health resources and who suffers the greatest burden of health. So for geographers, we're very curious about this. We want to see not just the comparison between places, but we want to see what makes up the health of a place, not just in maps, but in cities, in urban landscapes, in rural landscapes, to look at just how the health challenges on the left side of the street are going to be fantastically disproportionate and different from that of the health needs on the right side of the street. So today's lineup, here's what I'll go through. I'm going to talk about health in place, the social determinants of health in terms of how geographers look at it, the social turn in health geography. This was the most exciting moment of 1993 if you were a health geographer. So we're going to relive that play by play. Moving beyond maps, and I want to tell you about some research that I did a few years ago in Canada's Arctic regarding tuberculosis. And the point of today is that geography is about understanding the connections between land and life. And while not every subfield of geography is concerned with health, health is always impacted by geography. And that's what I'll share with you today. Now, interestingly enough, National Geographic, a popular name, household magazine, did a survey about the role of geographic illiteracy a few years ago, and they found that there was high levels of geographic illiteracy in most countries. But in the United States, it was particularly special, that the general lack of geographical knowledge in the US was a concern. And I don't just mean naming the state capitals and world capitals. You might do very well in a quiz night if you do that, but in terms of really understanding global connections around the world. And more recently, we do have to acknowledge that the geographic illiteracy has become quite a concern. Even when we see President Trump's statement a couple weeks ago that we cannot have prosperity if we're not healthy, Nambia's health system is increasingly said, well, there is no such thing as Nambia. It was either an attempt at Zambia or Namibia. In either case, we see the geographic illiteracy hitting the highest of offices. Now, all joking aside, when we look at things like the Ebola crisis in West Africa, geographic illiteracy matters. And it matters in terms of how policies get structured, how foreign aid gets dispersed, and ultimately how we approach a health calamity. A paper that I have coming out this week or next week in the Journal of Human Geography makes the case that we overcame the Ebola crisis in West Africa in 2014, not from an invention of science per se, but through dedicated knowledge of place and people working on the ground to take care of each other. If we could just revisit this quickly for a minute, when we look at the Ebola crisis that took place, you know, Ebola can be survived. You can contract Ebola and make it through, providing that you have access to health resources. When you look at the map of where the Ebola crisis took place, these countries here that had the active outbreak are all countries that have the most feeble public health services in West Africa. And that is not a coincidence that this public health emergency took place in areas that have had long-standing de-investment in public health and healthcare services. Now that's an important starting point to develop geographic literacy about the health issue here. It's not just where Mali, Guinea, Sierra Leone, and Liberia are, but what has gone into their social, economic, and cultural geography to make Ebola such a dangerous emergency in these places. Now that's one thing. The other thing in terms of geographic illiteracies is how the world viewed this crisis. I mean, at the height of the mortality of Ebola, in August 11th to August 17th, August 7th, 2014, about 13 fatalities a day from Ebola. During that same period, as this display shows, there were 685 deaths from HIV, 552 from malaria, 404 from diarrheal diseases, 110 from tuberculosis, and Lassa fever claimed 14 people on August 11th. Now, all this to say is that on a comparative scale, the other health emergencies that were going on in Guinea, Liberia, Nigeria, and Sierra Leone far outweighed what was going on with Ebola. Respectively, in this case, the panic, the concern on a global scale for Ebola during this time was enormous. Meanwhile, even though the mortality rates for these other diseases were there, the alarm didn't factor in just as much. You also think about how the world represented images of Ebola during that time. Geographers are very concerned with how places get represented. You see the images of here, the healthcare workers who responded to Ebola with headlines in The Economist, for example, the war on Ebola, these masked figures that were trying to give an impression of something evil and sinister in this way. The other thing is that most of the footage, the representations of place during this time were that of mortality, not vitality. This image here is one of death. It's not one of robust healing. It's not one of that expresses that this is going to be a situation to be made healthier. And the media followed suit, right? Calling it the ISIS of biological agents, CNN did. They also reported there is no end in sight for the unprecedented Ebola outbreak in West Africa. Fox News did a survey to show that 50% of Americans thought that ISIS was the greater threat to US citizens. 27% felt that Ebola, and 18% thought it was equal. Other headlines: mass hysteria, pandemonium in New York City as there was a patient just simply being tested for Ebola. Protests were taking place in front of the White House, even though during that time, during that year, there was more mortality in the United States from football-related deaths than there were from Ebola. This sort of panic plays right into policy, and in many cases, poor policy. Poor understanding of place leads to reactions, fears, and then policies such as this, where the World Health Organization critiqued Canada for putting on an Ebola visa ban for anyone coming from West Africa wanting to enter Canada. They were given a visa ban. As well, there was additional screening put in place in the United States for people who could be identified as coming from an Ebola region. North Korea just banned everybody for a while. That's probably a good thing. And in a turn of events, Rwanda started to screen Americans, even though Rwanda said they were being, citizens from Rwanda were being screened upon entry to the US for risk of Ebola. Rwanda said, do you understand how big the geography is between East Africa and where this Ebola region is? So in a turn of events, they went as far as doing thermal scans on Americans coming in to visit the Ebola, to visit Rwanda, because there had been a mortality in the United States from Ebola. When the cries for help came out from the World Health Organization, they said we need more experts on the ground, we need more funding, we need more support, we need volunteer support needed for Ebola outbreaks at Médecins Sans Frontières. What actually came down, how governments responded, were in the following ways. The United Kingdom provided £230 million. They built 100 hospital beds, and they sent 750 soldiers to the region. The US provided $175 million. They sent 3,000 soldiers, a command center, and an airlift of 50,000 home health kits from Denmark. And Canada, we sent $35 million to the UN. We gave a mobile lab to do testing there. 1,000 vials of vaccine that took 2 years to get to Africa and was never really proven to work, and finally 2 million gloves. Now, this is the response to Ebola in this region, even though experts on the ground, World Health Organization, Médecins Sans Frontières, said we need people taking care of other people. And all we did was send things. There were, yes, a few physicians from all of these countries who went over, but not to the level that was needed. It is why it was so important when Cuba answered the call by sending 465 of their own physicians over to the Ebola region. And when they got there, all disease experts, infectious disease specialists, who came on the ground, hit the ground running, immediately they said, we need to change the identity of Ebola in this place. We've been portraying it as something of hopelessness and misery and disease, and we need to embrace this as a proper health issue. And that started by not showing scary photos anymore, giving the thumbs up, no more photos of patients being taken, and ultimately approaching this illness with confidence as healthcare workers, not in terms of panic and pandemonium. And again, when you look at how this matters, that in 6 months after the Cuban delegation showed up, the fear started to subside, and Ebola was effectively under control 8 months later. This is why geography matters. Because once you understand a place, you can start to cater your global health response more effectively. And what geography really gives us? An understanding of place far beyond borders and physical environment. Well, it's not just about making maps or understanding differences between places. It's about trying to understand why places are so unique. It provides an understanding of place to include the social, the cultural, the economic, the environmental factors, upstream determinants, as I'm sure you're quite familiar with. It also allows for the appreciation of local capacities and solutions to local health problems. Incredibly important. So occasionally, I've given talks on global health and to physicians and non-medical professionals alike, and I show 3 injuries that are going to take place. And I'll show these to you now. The medical professionals tend to have a certain response, and geographers tend to have a very different response. My question is, what caused these scars? You look at scars like this, someone might say a whip, a lash, a knife, right? The sort of very deep fibrosis scarring that you see here. And that's legitimate. But a whip and a knife or any sort of tool that can cause harm doesn't do so unless someone's employing it. So to understand what caused these scars, it's not just a whip or a knife. It's maybe related to the fact that if an individual is an artisanal miner in the Congo, illegally mining resources in that region, and this is the consequence for challenging local authorities or local militias, then we start to see that such scars aren't just a product of a knife or a whip. They're the product of a geography that makes it much more likely to happen to some people over others. Another example, if I ask what is causing this severe eye irritation, right, the answer pepper spray is just simply not enough. Right? We have to understand the complex geography of Jerusalem, that to be a protester in the old city, to stand out against authority, may result in this injury that would likely not occur if the geographical conditions were different. And again, when I ask what is going to cause the concussion, is it the stick, is it the police officer, or is it a complicated economic geography in Bangladesh of people protesting and challenging the system in order for fairer and better working rights? So while the medical practitioners are going to be quite interested in how to make things better by dealing with the injury downstream, for geographers, we're very interested about how certain politics and places lead to certain health outcomes. And that's where we get involved. We're concerned with the very, very upstream determinants of health. We're interested in the environment. We're interested in culture, society, economics, and class. And from there to have conversations about how we can make places healthier. And usually that comes down to making places more equitable. It also comes down to understanding the very definitions of health. There's several of them, and I've taken a few from biology textbooks and medical textbooks, and from the one from the World Health Organization. You know, one definition of health is the overall condition of an organism at a given time. Soundness, especially of body and mind, freedom from disease or abnormality. The level of functional metabolic efficiency of a living being, or you could look at it in this way, the state of being free from illness or injury. And finally, the state of complete mental and social well-being. 1 and 3 are very much biological. That's just sort of the state of health. But 2 and 4 are very interesting because these both come from medical textbooks, and they're also the most common definitions. If you type it into your dictionary on your Apple dictionary or whatever it's going to be, you'll probably get a definition of health that'll sound a lot like 2 or 4. The problem with 2 or 4 is that health is being defined for something that it is not, which is a bit of an issue when you are the person who writes dictionaries, because you could look up the definition of an apple and it does not say it is not an orange. You know, a definition of an apple is usually pretty specific, and yet health remains vague. So that's where we come to the fifth definition, the state of complete mental and social well-being. That's what the WHO encourages us to think about health, but do we really understand what creates a state of health? All the factors that go into that? Or do we often view health as just simply an absence of illness and then treating it in that way? So for geographers, the interaction of people in a particular place matters enormously to understanding how health determinants will be shaped. It's not merely the location of people, but the interaction of people through class structure, through inequity and access to resources within a place. So we're very interested about how human behavior and the interaction of human behavior with the natural environment lead to certain health outcomes. So for example, this photo here, you see down that fence line a fantastic difference in health outcomes. Right? You've got an entire neighborhood compressed into the size of a tennis court. Clearly, there's going to be very, very different health challenges on the left side of the street than there is on the right. But why is that? What really makes that health status so much more vulnerable or at risk in certain areas than it is on the other side? Right? So to look at this, to just say the map of Sao Paulo gives us a sense of health isn't enough. We have to look at it very, very carefully, neighborhood by neighborhood, scale block by scale block. And this is where geographical tools come in and become quite important. So we see that places are ultimately structured by the social determinants of health, right? Now, here's and usually what geographers try to do is map this out, try to create that challenging task of putting a three-dimensional object on a two-dimensional space by drawing maps. And we do it in this way here. So here's a composite health rank for Canada. And if you look at the different health factors that go into this, you see there's some places that are more healthy than others. Vancouver usually gets a pretty good reputation. If you look here, Vancouver Health Service Delivery Area, composite rank 10th healthiest place in Canada at 101. There's your asthma rate, cancer incident rate, diabetes rate, overweight, regular access to physicians, 78.4%. Calgary does fairly well for itself, 6 out of 101. And if we come closer to where I'm currently located, Nova Scotia, not so great. We've got a few health challenges here. And so the question that geographers would come up with is to say, why is there such a disparity and a difference between this place, say Quebec City, to that of Central Ontario? Why does health change in the way that it does from place to place? Well, in all these issues, in all these areas, we see that there's a different lifestyle, there's different economic, there's different geographies involved with it. One of the things that we know, for example, is that smoking is a pretty clear determinant of lowering your health outcomes. And in that map, we could map out where smoking rates are. We see that if we go back to the map, we see that there's higher smoking rates in northern Quebec, 18.1% smoking rate here in Nova Scotia. You see that people who are of lower income are likely to be those who smoke. People of a higher income level don't smoke as much, men and women together. Yet we rarely think about smoking in terms of a class or a geographic phenomena. It often comes down to an individual's behavior choice. And maybe there's room to actually look at this in greater detail as a class and a regional phenomena, and from there, structure policies and innovations and ideas that could help people overcome the health challenges of smoking. So how did health geography and geography in terms of getting involved with global health really evolve? Well, there's a whole subfield in geography called, believe it or not, health geography. And this started in the 30s, in the 40s, maybe even earlier. But we usually come back to the scholar Jacques May, who looked heavily at disease ecology. There was a tendency to look at the association of a place to various illnesses, various health challenges, and to really try to create a connection between the environment and those health outcomes. This is the way that the early stages of health geography unfolded. From there, from the 1960s and into the 1970s, disease and environment, disease ecology, became the way forward, to do more mapping, to draw out how diseases and environments interact, to look at the spread of malaria, to look at the spread of tuberculosis, and there try to get a visual handle on the relationship between physical environment and that of various diseases. In the 1980s and into the 1990s, geographers really got interested in mapping and mapping spaces to look at using statistical data and trying to arrange this in maps either here at a national scale or very, very small urban scale to look at differences, to find trends, and to take statistical and complex data and visualize it in a way that could be digested and interpreted through quantitative methods. And in this era, this seemed to be the place of geography when it came to global health or to health studies writ large, was that geographers are the ones that made the maps. This is what we did. Well, in the 1990s, the conversation got a bit more complicated, because as much as we can map space, do we really understand how health is determined from place? So here in the favelas of Rio, how can we get a better sense of really what goes into constituting healthy versus unhealthy environments, housing, urban spaces, green spaces that all contribute towards health? So for example, what constitutes an unhealthy place? I could show you this photo here. You know, there's some garbage on the street, there's some cars broken down. The place needs a coat of paint, clearly. And you might look at this and think, this is clearly not a healthy place. You see this neighborhood, on the other hand, it's cleaned up, the windows are in, cars seem to be functioning, traffic lights are working, businesses are in effect. Might look okay. But even then, this is quite deceptive, because this environment is the Hillbrow region of Johannesburg, one of the most violent and dangerous regions of the city, and thereby also having one of the worst health determinants in Johannesburg. Meanwhile, that earlier photo is of Havana, Cuba. So yes, the buildings literally fall down from time to time, and yet you have one of the most robust healthcare workforces on the planet, so much so that their health workers serve some 110 countries around the world. So just by looking at the physical urban environment isn't really enough to understand what makes a place healthy or not. And it's not enough just to simply map it, to take statistical data. This all is important in getting a sense of place, but we really need to understand social theory. And the social theory that tends to run strongest through health geography research is that of inequities. And this came about in 1993 when a geographer from New Zealand, Dr. Robin Kearns, argued in 1993 that medical geography was overlooking important social dynamics. He was considering that health may be a product of that fifth definition from the World Health Organization, that we need to look at society, we need to look at the upstream determinants to get a sense of it, and that medical geography was just simply mapping stats and data and really trying to join the club of health practitioners. This was met with a lot of resistance from medical geographers. You can follow the debate in the professional geographer that went from 1993 to 1994. If you were studying geography in this time, this was excitement beyond belief. This was a head-to-head clash between the social scientists, the medical scientists, the quantitative theorists. It was playing out high-stakes drama, my God. But what it was really about was the medical geographers worried that including social science in the discipline would not be taken seriously by medical professionals. That was the talk in 1993. Kearns argued the opposite. He said that social theory and geography would lead to better understandings of health rather than just simply the absence of disease. And as a result, this led to an increased focus on inequity, class, race, and gender as being issues that can be understood through geographical methods and then also used to inform health policy and health outcomes. But also the inclusion of issues such as culture, emotions, post-structural critiques of biomedicine, and the rise of a concept called healing landscapes followed in the 2000s, where we're now almost into an anti-biomedical subfield of health geography that gained a lot of popularity within the discipline between 2003, and it still carries on a bit. But many health geographers, especially those who are interested in policy outcomes or engaging with global health work, look at this idea of inequity. So at the time that Robin Kearns was making his case, Richard Wilkinson was making a similar case about the role of class and how that determines the health of a place. He looked at the Whitehall studies in the 1960s about labor issues in the UK, about how class standing and the amount of income earned created fantastically different health outcomes amongst workers in the British Civil Service. Extending on that, there's some other interesting phenomena. Say in World War II Britain, at a time when the country was being actively bombed and men and women were fighting on the continent, and there was an active state of war. People were sleeping in the tube stations at the time. An interesting phenomena took place. And that is, if you look at the life expectancy in years in Britain, 1931, and we have income per capita here at the bottom, there's 1930 to 31, 61 years would have been the life expectancy at that time. Then in the 1930s, life expectancy in the United Kingdom, it went up, it went down, it kind of went back, it stagnated, but then World War II kicked off, and in that first year, life expectancy started to go up, and then when we get to the establishment of the National Health Service, 1950s, there we see more of a clear tendency to see life expectancy move up. Other health indicators measured the same way, but the idea that you could actually see an increase in life expectancy during a world war was actually a fascinating revelation. And what it showed is that even though England was at a state of war, the fact that there was full employment, that there was now more regular access to some medical care and to better nutritional services actually increased health outcomes, meaning that in the 1930s and the 1920s, if you're a Downton Abbey fan, as much as I am, you'll know that being in service was a way of receiving some sort of structured form of employment because there was no social net at that time. So during the war, those who were at the bottom came up a little bit. They had better access to resources, employment, food, and those at the top, such as Princess Elizabeth, now Queen Elizabeth, she wound up being on rations too, and being a truck mechanic during the war years. So there was this narrowing of class inequity in the 1940s. And so what we see is how London mapped itself out in ways and organized its space to actually see health outcomes intentionally or unintentionally improve during the war years. So today we're still very interested by that as geographers to continue mapping things out. When you look at, you saw the map earlier, that Vancouver was rated the 10th most healthy district in Canada. At a closer look and scale, you can see where the serious poverty issues occur within the city, and that also really changes the health mapping of the city as well. So in a sense, geographers were interested in the relationship between disease and environment. Then we started mapping things out, and we wanted to basically visualize and create these very rich comparisons and these overlayers of maps to look at health issues. And then in the 1990s, we decided to bring social theory into the game to look at issues of class inequity and other things that divide people out. Now, my own piece of research will take us up to Canada's Arctic, which looks at issues of tuberculosis. So when I was up there in Iqaluit in 2010, it was actually a monumental time. It was Tim Hortons. If you're from Canada or if you've been to Canada, you know just how important this is. It's a national chain. We have a strange addiction to this coffee and donut shop, except for Nunavut. And at the time, we were celebrating because finally Tim Hortons had arrived in Nunavut, in Iqaluit, and there they were. You can see that they've got the Inuktitut language above the Tim Hortons. Finally, the country is united at last. But at this time, there was another reason to take a notice of what was going on in Nunavut, and that was the rate of tuberculosis, if we look at it per 100,000. So 3 countries at the bottom here. If we look at it at a national scale, this is the cases per 100,000 in these countries. South Africa and Botswana, obviously, HIV/AIDS emergency cases. India has struggled with tuberculosis for many years, but Canada, at a national scale, 5 per 100,000. We're doing pretty good on tuberculosis until you get to the territory of Nunavut, where it would reshape that ratio to look like this. And if you look just at the city of Iqaluit, that's our TB cases per 100,000. Extremely high. Another way of looking at it is that if you look at who is getting tuberculosis, if you are a Canadian national, not from the First Nations communities, you probably don't have tuberculosis. Maybe if you're foreign-born, you might. But if you are of First Nations, being Métis, North American Indian, or Inuit, using the legal language from Ottawa on this, you see that to be Métis, you have a higher risk. To be First Nations, a very high risk. And if you're Inuit, that's the rate of TB amongst our Inuit population. What's more, in Iqaluit during that time, the change in cases per 100,000 was growing like that. That is uncontrolled growth of active tuberculosis. So today, in 2017, there are 83 active cases in a population of 6,616. That does not include the latent cases. These are cases that are being followed with direct observation therapy short course. So again, we look at the world, there's a map. When you look at tuberculosis, you don't really think about Canada until you come to Iqaluit. And again, I'll just put you back on this map as to where it is. It's right here, Iqaluit. And so the general health rate here, very low, 79 out of 101, high asthma rate. You're looking at, again, high smoking rate, and the regular access to doctors only 16.7% in Baffin Island there. Many people relying on nursing stations to get their primary care needs. So what you need to know about tuberculosis in Nunavut is that there's testing. Some of it is handled locally. Some of it they have to ship samples away to Ottawa and to Edmonton. There is monitoring, and there is treatment as well. So this is all very good. I understand that my audio cut out for a little while there. I do apologize if that's the case, but it's good to have you all back. When going up there to work in Nunavut, working with people in the government, the response was that TB couldn't be eradicated. It's part of Nunavut. Again, geographical literacy coming through. The problem is poverty. We need to clean up the water, almost. Water is a different issue. Health Canada said we'll increase funding for treatment, monitoring, and research, and our health minister at the time said that as Northerners, we're very familiar with tuberculosis. That really didn't say much. But we're up there, and I was invited to come up and do work here to try to identify where the source points for tuberculosis were occurring, to figure out where the cases were and to try to map it out. And we found 3 clear places where tuberculosis was impacting the population. One was overcrowded housing, such as here. So the Canadian medical overcrowded housing was one, also the jail, and also the homeless shelter, which we'll get to in a minute. The Canadian Medical Association Journal said that Nunavut recorded the largest tuberculosis outbreak in its territory's 10-year history. And what's more, proper public health measures are in place, but they're under-resourced. And the CMAJ said the eradication of TB will require long-term economic investments to combat poverty. Now here, that's a very important piece of advice because we need to understand the geography in order to get those investments correct. So source point 1, we found poor housing. That 36% of people living in Nunavut live in overcrowded housing due to the point of hot bunking, meaning that people are sharing beds on different shifts. Someone will take the midnight to 8 a.m. shift, someone will hop right in the bed from 8 a.m. to 2 p.m., and then another person will keep going and going. Even with additional public housing, overcrowding is not expected to ease up, and up to 13 people could be living in a dwelling, like I'll show you in a minute. Others take 2 fishing huts. Poor ventilation, poor heat, damp insulation, it's not great. So in a building like this, up to 13 people could be living in it. Very crowded conditions with no ventilation. It's perfect for the spread of tuberculosis in housing environments such as this, or even fishing huts where people were living. The lack of ventilation, the dampness, it's not helping the cause. The government was putting in new housing to look like this, but again, making similar mistakes in terms of quality. There's no forced air. There's very cheap insulation being used. This is likely not solving any problems. And what more, when you actually look at, again, from a geographical point of view, access to food and food security, in Nunavut, it's a bit tricky. I'm sure we've all seen these food guides here about, you know, your carbs and your leafy greens and your protein, but in Nunavut, they also have this section over here of country food, which might involve muktuk, which is the blubber from whale, or caribou, or seal meat, this kind of thing as well. There's a serious crisis in Nunavut when it comes to the cost of food. 2 liters of orange juice can run you about $10 Canadian. We have a program to bring some produce up, but that's $4.99 for a kilo of lemons. That's a bit costly still. And you see just the cost of food, $30 for a jar of Cheese Whiz, $31 for a 24-pack of Pepsi or 7-Up. Pizza Pops, they're on sale this week for $32.79. The cost of food leads to poor nutrition and thereby impacts on people's ability to be resilient against tuberculosis. Same thing with the jail. We also mapped out issues with the prison. It was overcrowded by almost double. Many people were in there for pre-trial, and up to 30 inmates sleep in bunks or on the floor. Guards and staff all tested positive for TB, and treatment is available once it's ill. So here in the Baffin Island Correctional Center, this is an older facility that was overcrowded. The men were being put in bunks like this. Active tuberculosis can spread very, very quickly in this environment that does not have proper air circulation or any sort of safety measures put in place during this time. Finally, we also looked at the homeless shelter to show that it wasn't necessarily overcrowded, but the ventilation system hadn't worked in years. It draws between 7 and 8 per room. With no air circulation and tight conditions, tuberculosis spreads. Even to the fellow working at Tim Hortons. There was a guy there who was working at the new Tim Hortons, but was staying here in the homeless shelter because he couldn't afford to live anywhere else. So from a point of view of geography, we would take a look at the issue of housing, the issue of overcrowded prisons, and the issue of the homeless shelter, and try to find ways for solutions. But public health education doesn't really touch on that, right? We see that there's literature available to try to destigmatize the issues of tuberculosis, but it doesn't really push towards prevention, right? So ads like this may help people normalize living with tuberculosis, but it doesn't really do much for giving sound advice on how to prevent it. And when you look at those who are at the highest risk, they're also those who are at the most vulnerable. What can we do for strategies in this area? How the Canadian government responded to this, even though the housing was the root of the problem, there was just no real coordination to deal with the geographic challenges at the time. So when, at the time, the health minister announced an $800,000 budget for a program called TAMA TB, TAMA means stop in Inuktitut, there was $800,000 announced. It went to support medicines for TB patients, which was already in the federal budget, to hire additional nurses to monitor door to door, even though there were already 18 nursing vacancies. Getting people to work in Iqaluit is difficult. And they spent money to create a Facebook page for public awareness. So the program TAMA TB put those measures in place that really don't deal much with the upstream geographic factors. When it came to the Facebook page, when it was originally posted, they did it wrong. They set it up as a person. So people started to like tuberculosis or think they're cute. When they eventually set it up as a proper group, most people who were following it were researchers and healthcare providers, not the actual people living in overcrowded conditions or in the jail. So all this to say is that when you approach global health without geography, it kind of leads nowhere. To keep a geographical lens on the upstream determinants of health is incredibly important, because not just in this case in Nunavut, But in any case, when you really want to understand the difference between the health determinants on the left side of the street versus the right side of the street, geography matters. And if we have time, I'll take some of your questions. Thank you very much.
Thank you so much, Dr. CUGH. We are so thankful for your perspective, and you presented a wealth of information. I want to invite questions and comments. Use the box on the right side of your screen. Our first question is, you have pointed out how important geography is to understanding global health. And I'm wondering what you found to be successful to reach across silos on campus to bring together different departments to teach and understand global health through a multidisciplinary lens.
Thank you very much. The thing that geographers can do is literally speak many languages. We're very interdisciplinary and collaborative people by nature because there's so many social and economic and quantitative dynamics to health that can be mapped out and discussed through the views that I've mentioned here. In the past, we've seen that geographers have been, just even on this campus here, have been welcome to participate in health science research projects and grant funding as well. But also, there are forums and opportunities to be very collaborative with health professions. Anytime that someone in the health sciences is interested in anything to do with mapping or to understand how to visualize or conceptualize issues of inequity, call a geographer. We're really friendly people to hang out with. I guarantee you that. So that's usually the way to create those interdisciplinary connections, is by working together, as opposed to try to be isolated and just publishing or doing research within the silo.
Thank you. We have a question from Kathy Burke. Seems like there's a lot of overlap between epidemiology and health geography. Can you comment on that?
Sure, there is. Epidemiology speaks to a lot of the similar issues that health geography is focused on. Only that with health geography, there is more of attention to issues of class inequity and social inequity within places, where we're definitely concerned about the measuring and the monitoring of health outcomes, but also really understanding the dynamics of how people interact with each other, how access to resources are divided and shared at a local level. So as much as I've had the opportunity to myself work with epidemiologists in Ecuador, and again, their theories, their practices are always welcome input into geographic work and research. And again, it's just it's a lovely match that geographers can make with others, amongst many other disciplines as well.
Excellent. And it seems that to translate the lessons from geography into action, there would need to be skills in advocacy and public awareness building. Can you comment a little bit about the importance of those skills and how you see that as a next step from the information that geography can help understand?
Yeah, great. I mean, it comes back to what I mentioned earlier about geographical literacy, that it's not just a comical thing when the president misspeaks. It's actually really fundamental in terms of how we conceive of both our local places and places abroad, in terms of how to strategize for health issues. One of the greatest misconceptions, I think, within global health is that there's a lack of capacity or a lack of local resources and knowledge in many places to deal with and overcome health challenges. And this is where geographers come in, where there's the ability to not just map out or to draw quick images of places, but to really discuss how the economic foundations, the social foundations, and the cultural foundations exist within places. Graduate students who do master's research or PhD research, any one of their theses will be to pass a geography degree, you pretty much have to create a very respectful and careful representation of a place. And I think that the more we're able to overcome stereotypes of how places are conceived and really get to know the capacities and commonalities, the better we'll be. But again, geographical literacy, so important.
Thank you. Sheila Davis says, I contend that inequities boil down to systems of oppression and white privilege. What do geographers have to say about this?
I think Sheila's right on the money. There is an entire subfield in social geography that looks at and explores that very issue in terms of privilege and class and inequity. This is some fantastic work that have been done by geographers at universities like Queen's University, Simon Fraser University, University of British Columbia, that get right to the heart of that, that actually really unpack how colonial landscapes that from hundreds of years ago or even the recent past continue to shape geography today. And by geography today, I mean the interaction of people with each other and people with the physical environment. So that's a fantastic point. And there's a whole subfield of geography that explores that.
Wonderful. And one thing that can be helpful is people understanding what conferences, meetings, and gatherings happen within geography that are really seminal. Could you just mention a few of the key conferences and meetings?
Absolutely. So 2018 is going to be a very fun year for geographers and on the conference circuit. There's the International Studies Association meeting. This will be taking place in San Francisco at the beginning of April. This is a very interdisciplinary meeting, but geography is one of the core pillars of it, where you're going to have scholars from a wide range of disciplines, political science, sociology as well, that do come together, but it's a wonderful networking opportunity. And then there's the American Association of Geographers. Their meeting is taking place shortly after that in April in New Orleans. So, I've signed up for that. I would welcome you all to come by, and we'll, have a great time talking about health geography there. These are not meetings that are exclusive to geographers. You're certainly open and welcome to participate in these venues.
Thank you. And we'll also mention that leading up to those April meetings is the CUGH annual conference, Exploring Health Disparities, A Time for Action, taking place in New York. So please visit CUGH's website for more information, www.cugh.org. I'm getting many comments from Lenny Pack, from Alan Tashtintu, saying what an excellent presentation this was. And I want to thank you, Dr. Hewish, for joining us today and for bringing light to this subject. Thank you so much. And thanks, everyone, for joining us. Please join the next installment on November 16th at noon Pacific, 3 p.m. Eastern. And visit Dr. Hewish at Professor Hewish and CFHI as well. Thank you so much.
Thank you, Jessica. It's been a pleasure to spend time with all of you. We'll be in touch, I'm sure.